صلوات على محمد وآل محمد. We'd like to start the program with a recitation of Quran by Maryam Asaria.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. إن عبادي ليس لك عليهم سلطان وكفى بربك وكيلا. ربكم الذي يزجي لكم الفلك في البحر لتبتغوا من فضله إنه كان بكم رحيما. وإذا مسكم الضر في البحر ضل من تدعون إلا إياه فلما نجاكم إلى البر عرضتم وكان الإنسان كفورا. أفأمنتم أن يخسف بكم جانب البر أو يرسل عليكم حاصبا ثم لا تجدوا لكم وكيلا. أم أمنتم أن يعيدكم فيه تارة أخرى فيرسل عليكم قاصفا من الريح فيغرقكم بما كفرتم ثم لا تجدوا لكم علينا به تبيعا. ولقد كرمنا بني آدم وحملناهم في البر والبحر ورزقناهم من الطيبات وفضلناهم على كثير ممن خلقنا تفضيلا. يوم ندعو كل أناس بإمامهم فمن أوتي كتابه بيمينه فأولئك يقرؤون كتابهم ولا يظلمون فتيلا. ومن كان في هذه أعمى فهو في الآخرة أعمى وأضل سبيلا. وإن كادوا ليفتنونك عن الذي أوحينا إليك لتفتري علينا غيره وإذا لاتخذوك خليلا. صدق الله العلي العظيم.
Thank you very much. We're now very fortunate. We're now very fortunate to have Dr. Yasmin Al-Asady, who will be speaking to us on the topic of ADHD, too fast, too furious. Let's welcome with salawat ala Muhammad wa ala Muhammad. Dr. Yasmin Al-Asady is a North London-based child and adolescent psychiatrist, passionate about challenging the stigma around mental health and disability. I'm very fortunate to have her here, and she's also a member of the community. Salawat ala Muhammad wa ala Muhammad.
Assalamu alaikum, everyone. Thank you very much for inviting me today. It's an honor to be invited and a privilege to be here to share with you today something that I am very passionate about, something that I've spent a lot of time working in, a field that has taken up a lot of my time and energy. And I'm curious as to how and why this came about to be on the schedule of talks here at Mahfil. And maybe, will we have time at the end for questions? How much time shall we just keep going? Okay. So the title, Too Fast, Too Furious. I wanted to challenge you all at the end to think about what your preconceptions are about ADHD, what your thoughts even are, what your experiences are. What I'll try to do is explain a bit about the neurobiology. And this is a hugely broad subject, a hugely contentious issue, lots of esteemed psychiatrists disagreeing with each other, and jobbing psychiatrists like us stuck in the middle. When I was debating whether or not to give you this talk today, I had the misfortune of listening to a telephone phone-in on the radio. I won't say which station. And it was just after Jeremy Hunt has made wonderful comments about SEN being overly diagnosed and too many children requiring EHCPs. And I think his words were, "We are forgetting that childhood can just be messy." And I thought to myself, maybe I should come and talk. because while I agree with him that childhood absolutely can be messy, it made me think of all of the patients that I was seeing on a daily basis who have that messy childhood, but for whom it was amounting to much more than just the normal mess of childhood. And so I'd like to bring that to you later to think about what your thoughts are about overdiagnosis, or diagnosis in general. I'll spare you the trauma of it being an interactive talk. We're not going to make this a medical school lecture of, what are your thoughts and what are your experiences? So fundamentally, what is ADHD, attention deficit hyperactivity disorder? It's a neurobiological developmental disorder. It's related to the brain, and it runs in families. It impacts child's development and ability to learn. 1 in 20 children are diagnosed with ADHD at some point in their lives. Now, of all of those 4 things, there are psychiatrists and neuroscientists and many other fields who would dispute all of those things. But those are the premises that we're working from today. So within psychiatry, we use something called the International Classification of Disease Manual. That's the European version. In America, they use something called the Diagnostic and Statistical Manual of Mental Illness or Mental Disorder. And so the easiest way to explain what ADHD is to just go through the criteria. So I'll read it verbatim, and I'd like to hear your thoughts later about it. So attention deficit hyperactivity disorder is characterized by a persistent pattern, at least 6 months, of inattention and or hyperactivity or impulsivity that has a direct negative impact on academic, occupational, or social functioning, evidence of significant inattention and or hyperactivity or impulsivity symptoms prior to the age of 12, typically by early to mid-childhood, though some individuals may first come to clinical attention later. The degree of inattention and hyperactivity or impulsivity is outside the limits of normal variation expected for age and level of intellectual functioning. And it goes into a bit more detail about inattention, referring to significant difficulty in sustaining attention to tasks that do not provide a high level of stimulation or frequent rewards, distractibility, and problems with organization, something that's often missed when we think about inattention. Hyperactivity refers to excessive motor activity and difficulties with remaining still, most evident in structured situations that require behavioral self-control. And impulsivity, a tendency to act in response to immediate stimuli without deliberation or consideration of the risks and consequences. The relative balance and the specific manifestations of inattentive and hyperactive impulsive characteristics varies across individuals and may change over the course of their development. So it's a lot, and it can mean many different things for many different people. Thank you. Critically, it goes on, manifestations of inattention and or hyperactivity and impulsivity must be evident across multiple situations or settings, so for example, home, school, and work, with friends or with relatives, but are likely to vary according to the structure and demands of the setting. And symptoms, the last line, are not better accounted for by another mental, behavioral, or neurodevelopmental disorder, and are not due to the effect of a substance or a medication. So it could be anything, really. And I think this is where the contention arises. Is this a disorder? Many people will say it's not, because actually when we look at the definition of a disorder, we need a physical locus, we need something to focus our attention on. What is the problem? Whereas actually critics will argue that ADHD, as described in the ICD or the DSM, is a behavioral description. It's just a collection of symptoms that some people experience, and therefore it's not actually an illness, and we are pathologizing children. We're telling them that you have this thing, and it's a thing that we have no evidence for, theoretically. Now, the last line is very important about not better explained by another illness, a mental illness in particular, because a lot of critics will say that actually, and Gabor Mate is a big proponent of this, Daniel Amen is a big proponent of this, where people describe ADHD as a coping mechanism. This is a product of trauma. If somebody has experienced complex trauma throughout their childhood, or if they have a big traumatic event, actually you might view ADHD, the hypervigilance, the distractibility, the inability to focus, the constantly be worrying about what's going on, as a trauma response. And it's actually a protective measure, and that you're then going to pathologize and treat, which is a fair criticism to a degree. However, we can have a both-and situation, in the sense of it can be as I said, a response to trauma, but it can also, there's an overlap between what a trauma response might look like, but also a degree of dysfunction that it impedes their behavior in their life. And that's when we start going into the realms of neurodevelopmental disorders. And up until about, I'd say, 10 years ago, the data was quite patchy. So one of the problems we have in psychiatry is our ability to identify these locus, where these difficulties arise. And a lot of our data is incidental. So if you think about the serotonin hypothesis in depression, the scientists noticed that there were varying levels of serotonin for people suffering with depression, and antidepressants which increase serotonin, therefore are helpful, and so serotonin must be at the center of depression. Similarly with ADHD, dopamine was noted to be variable in children with ADHD, and Ritalin, one of the main treatments for ADHD, increases dopamine levels, and therefore dopamine must be at the center. And then we have more recently much more neuroimaging, where we've been able to scan brains of children and adults with ADHD, without ADHD, on medication, not on medication. And there have been correlates of brain function that consistently show up as dysfunctional or as overactive, and therefore these must account for ADHD. However, we still do not have a definitive focus. And so critics or anti-psychiatrists will always say, well, if we haven't got that genetic locus, how can we say it's a genetic disorder? How can we say it's rooted in genes if we don't know which gene we're talking about? And I guess what I'm saying is that I think what I've emphasized so far is that it's complicated. We know that it is heritable. We know that there is up 50 to 75% of heritability where you see it run in families. Even though we can't identify the specific gene, it may be multiple genes interacting in ways that contribute to the brain structure and brain function. When we look at imaging studies, we look at brain areas which might be overactive or underactive, and then we also look at how they connect. So what are these areas that are identified? Well, we look at the frontal lobe. So the brain is split into various different sections, and the frontal lobe, the bit at the front, is implicated in ADHD. And that's the bit of the brain that is responsible for our executive function, for our planning, for our organization, for our attention, for our memory, some of our memory. The other areas involved are the basal ganglia, which sit in the center of our brain, which are responsible for movement and coordination, and where a lot of our dopamine is made and stored. And then there's the cerebellum, which is responsible for our coordination and how we bring things together. And then, as we said, dopamine has been implicated because it brings all of those areas together. So that's, in brief, what we understand about the brain and ADHD. But how does that manifest in real life? And does that in any way prove that ADHD is a neuro developmental disorder? It's up to you. You decide. Because the ICD has made its decision. NICE, the National Institute for Clinical Excellence, has made its decision. The DSM, the American Psychiatric Association, the Royal College of Psychiatrists, they all occupy one camp. I like to be balanced, not to channel the BBC. In the interest of balance, I think it's important to present both sides of the argument, because there are very vocal critics, and there are people who feel that they have been harmed as a result of this biomedical approach to psychiatry, and there are people who feel their lives have been saved. So I didn't want to come here to talk to you about ADHD without speaking to the counter-argument that say that this is inappropriate, for want of a better word. If we're going to take the premise that I've talked about in terms of the neurobiology that we've accepted based on the imaging available to us, and to explain it in simple terms, there's a really nice model developed by an ADHD coach in the States, whose name evades me at the moment, called the intersection model. And I just want to read you verbatim what she says, because it really makes things clear. So an intersection, an American intersection, we'll call it a junction. So within the frontal lobe, there's the immediate, right at the front, there's the prefrontal cortex, okay? And the prefrontal cortex is implicated significantly in ADHD. And it is the intersection through which attention, behavior, judgment, and emotional responses run. So in the intersection model, we're driving along and we hit a junction. And all of these things, the behavior, the judgment, the emotional responses run, they're the cars or the messages. So a person with ADHD will likely react to whatever is in their focus at that moment. In other words, it's the fastest or strongest car. For people with ADHD, the prefrontal cortex is unregulated. There are no traffic lights or stop signs controlling which message gets through first. So you could be the smartest, most motivated student ever, but the teacher says, this species of dog, and your thought switches to, I wonder what my dog is doing right now. you get distracted, and so on and so forth. So the only thing you can focus on is the strongest car going through that. And what that means is when we think about inattention, we think about the spectrum of symptoms. So when we talk about, classically people will think about concentrating at school, concentrating in class. But attention means concentrating in a conversation, having the patience, the lack of impulsivity to be able to wait your turn in a conversation. It means having the attention and the planning function, the executive function, to be able to organize yourself, to be able to pack your school bag, to recognize that you have maths tomorrow and English and science, and therefore I need those 3 things. To be not so distracted by that exciting thing going on in the playground that you leave your jumper on the bench. All of these things are the strong cars that's coming through. And similarly, something that's often missed in ADHD and something that we see a lot, certainly in the teenage girls that I would treat, is emotional regulation. So if you are unable to manage your attention and focus your attention on a broader range of things, if you're having a conversation with someone, and I'll take a simple example, if you're having a conversation with someone and they mention that they support a football team, and you definitely don't like that football team. I'm looking at someone in particular. I'm going to try not to make eye contact. And they're talking about this football team, and then they move on and they say, we're going to go to this. And all I can think about is the fact that they support this terrible football team because I am so animated by the fact that I detest this football team. Now, obviously, that's trivializing it somewhat, but that's why emotions can consume so much of of the attention span that one's not able to concentrate on what else is going on. And that leads to very strong and at times debilitating emotional reactions. And what have we talked about? We talked about organization, we talked about planning, we talked about emotion, anxiety, similarly. So if you are only able to concentrate on those thoughts, and then it develops into a ruminating pattern where you're consistently focusing on that at the expense of everything else, ADHD can lead to comorbid anxiety. And then if you're having all these difficulties socially and your peers or your teachers or your family or extended family can't understand what's going on for you or might not even know that you have a diagnosis, you develop these social difficulties because nobody has the patience to follow what you're talking about. And then you are ostracized. And then the social media bullying happens. And then you become lonely and depressed. So what stems from a very simple thing of just not being able to concentrate on a conversation can explode into a much bigger entity, at the center of which, sadly, through a lot of mental health, is shame. Because normal, the word normal exists because it represents the middle of that curve. It's what most people adhere to. If you work outside that normal range, it's a lot harder to toe the line. And so it might be thought of as an academic difficulty. It might be thought of as something that only happens to school-aged children or that only becomes problematic within the academic realm. But actually, most of the kids that I see, alongside the school difficulties, there are so many other emerging mental health difficulties as a result of the difficulties that they're experiencing. Family conflict, siblings. What does it mean to have to accommodate for your brother or sister or cousin or father or mother who has these difficulties and who might not be able to tend to your needs? I've got a picture of a synapse here. I'm not going to go into the details of neurotransmission because I think that's unnecessary. So if you suspect that you or someone has ADHD, what happens? What do you do? What are the barriers to accessing help? Is help available? Number one. Do you want help? Do you want a label? What does one do when they suspect that they're struggling? And it's interesting because actually, when we think of neurodevelopmental disorders across the lifespan, people will experience ADHD in different forms, in different flavors throughout different stages of their lives. So, for example, certainly where I work, you wouldn't be considered for assessment before the age of 6 because the symptoms are thought to be very in keeping with the behaviors of that developmental age. And then what happens is children will go to nursery. And often at these points of transition, when there's an extra load on the brain for these children to adapt socially and academically, and symptoms come to the fore. So we will classically see referrals at nursery, too young. We'll see referrals when kids get into reception year 1, year 2, when they're starting and then you have children who will develop strategies, who who will figure out that actually they need to do things in a certain way, or who figure out that they need to be fidgeting when they're working, or will figure out that so they, you know, these people are my tribe and these people aren't my tribe. And they will go under the radar because they're coping, because they're not having that functional impairment. And then they'll hit secondary school. And that's the other peak of referrals that we get, where kids suddenly have to manage going to different classrooms, having a different timetable, remembering what subject is happening when, what homework was for which subject, carrying the right books. I just had a flashback to how heavy my bag was in secondary school because I had every folder under the sun. Managing the loud hallways, and I'll come to sensory difficulties alongside ADHD. And so these are when we see struggles. And then we come to adult life. And then there are people who have the strains of having a high-pressure job. And suddenly they're not meeting deadlines because they can't motivate themselves to do that really difficult task. And they find themselves, perhaps because of their impulsive tendencies, self-medicating through drugs, alcohol, overeating. These ways where people cope, because for so long this was ADHD was characterized as either lazy or inadequate or not trying hard enough. I think because for so long, and this is one of my bugbears, for so long we've thought about a lot of the way we view success, for want of a better word, has been premised on this idea of meritocracy, where if you work hard, you should get to where you need to get to. But actually, for some people, they are swimming whilst being attached to the end of the pool. So they're going as fast as they possibly can, but they're never going to get anywhere because they're still attached to the what's at the other end? The wall. Let's go for the wall. Whereas the people who can just keep going without hindrance are going to get to those places. And this is the frustration so many of the young adults that I see have of, I'm doing my best, and the teacher keeps telling me I'm not listening. I am listening, but I've just got 101 channels going at once. Someone described it to me as, if you have a ballpoint pen and you click the pen, there's one nib that comes through the pen. And that's what it's like not to have ADHD. Having ADHD is like having one of those cool multicolor pens. You do have that. You do have that in your bag. A cool multicolor. Do you want to bring it and we'll do a demonstration? One of the multicolor pens where there are so many nibs trying to get through and there's just no way of regulating. And you can't choose which one's going to get through. You don't know what color you're going to get to. I'm trying to buy time for the pen to arrive, but never mind. I've lost my train of thought now. Let's have a salawat while I find my track again. Thank you to my lovely assistant. So, multicolor pen, where there are so many nibs trying to get through, competing, until one finds its way through, and it might not be the one that you want. So that's a nice way I find of describing it to kids in particular. You can try as hard as you want, but it's tricky. And so, I'll come back to this because I wanted to talk a bit later about strategies and how we cope, how we deal with these things, because it's difficult. The world is not designed. There is a reason it's called neurotypical and neurodiverse. The world is designed to work in a certain format. My friend who's 6'2" often says the same thing about height. He says that I'm average height. Some people say I'm short, but I'm average height. And they say that the world is designed for me. When I go to an ATM at the wall, I don't have to, they have to bend over and they have to hunch because the world is not designed for people who are 6'2". And similarly, when you traverse your world as a neurotypical person, you have to remember that actually it's not so easy for everybody. And I guess that's kind of the crux of everything that I talk about when it comes to mental health, is that we can only know our world, and that's fine, but it's our job, it's our duty, particularly in this age of information, to seek out information, to try to understand. And so when I read Jeremy Hunt's comments about SEN, special educational needs diagnoses, being overly diagnosed and too many educational health and care plans, and ultimately, and I'm glad he didn't beat around the bush when he talks about the fact that the financial impact of this is just too great and local councils cannot keep up, I find myself thinking, okay, well, fine. Okay, so what we're saying is that there are too many people who have a need. Does that mean that the need doesn't exist, or does that mean that we as a society need to rise to that challenge and help that need? What are we talking about in terms of school provision? Are we allowing schools, are we empowering schools to be able to deal with this, to be able to cope with a quarter of their class having a neurodevelopmental need? I do not envy teachers at all, because their job is incredibly hard. with little resource, with increasing demand. And I didn't think I'd be mentioning Nigel Farage, but I cannot help but think back to two very seminal points in the past decade, one being Brexit and the other being the pandemic. Now, I can only speak to this anecdotally. I can't say that I've researched it in any way, shape, or form, but the Brexit campaign eroded trust in experts and expertise. And so ironically, my first job in ADHD and neurodevelopmental services was 10 years ago as a junior doctor. And the climate was very different. The climate was exploratory and curious. It was patients coming, seeking to understand, patients struggling whose teachers had referred them in a hope of helping them. And there were, of course, waiting lists, nowhere near as where we are now. Whereas now, patients and families are so frustrated that they cannot traverse this world. They're so frustrated at the blocks and the barriers that it can be difficult to say no. The cases where I've said that I don't feel a diagnosis is relevant have been very, very difficult, not to implicate myself in any way, shape, or form as this is being recorded. And so one has to think, and I don't blame these parents or families in any way, shape, or form, because everybody can understand a parent's desire to advocate for their child. But with so much information available on TikTok and YouTube and all other social media platforms, I'm showing my age, I didn't say Facebook, it's hard to disentangle what's the correct information. And I must say I experienced that myself when I'm on long-term leave at the moment, so I haven't practiced in about a year, and my brain is a bit fuzzy. I would say I have transient ADHD, otherwise known as baby brain, and it's overwhelming, the amount of content online about what to do and what not to do and who's right and who's wrong. And for everyone that's saying that this is go and get your rights and go and get help, there's someone trying to sell a service, there's someone telling you you're wrong, there's someone telling you you're lazy, and it's overwhelming. And so if you imagine that prefrontal cortex at that intersection, you've got all of these things, you've gone looking for help, and then there's all of this information. It's overwhelming. And so we need trust in services. We need space for experts to develop. We need space, we need training. We need money. We need space for teachers to have training. We need extra resources for teachers so that they have the time. There is so much that we need, but ultimately we need society to recognize that actually we shouldn't be vilifying parents for seeking out an assessment, not a diagnosis, but seeking out an assessment. So that's my bugbear. And it relates to, as Miqdad alluded to, something very close to my heart, which is stigma. This is, mashallah, a very hard-working community. And hard work runs through our veins, as it does in lots of immigrant communities. And it's hard for such communities sometimes to accept that this isn't somebody's fault. Just try a bit harder. No, this isn't ADHD. Oh, I'm thinking in Arabic now. What's the word? They spoiled their kid. They give in to everything. They misbehave because of that. They should be able to stay still. All of these things come to the surface, and they are natural thoughts. But I want to challenge you to think, and if anyone's willing to share later, I'd be intrigued to hear your thoughts. The reason I called this Too Fast and Too Furious is because actually, is there such a thing as too fast? Or have we decided what pace one should be going at? And of course, one should be able to function, but what about too furious? What do we do with these children who we're faced with who won't adhere to the status quo? What do we do with adults who don't abide by the rules that we have decided are appropriate? How do we deal with difference? And so much of that comes down to us. What do we feel about difference? And where do those thoughts and feelings come from? One of the, again, the reason I raise Brexit is because actually one of those difficulties when you talk about welfare and benefits is, well, they're stealing our benefits. They're taking our school places. My kid can't get support in school because the teacher is distracted by that disruptive kid and they just need to be disciplined. And so all of these thoughts, however ugly they might be, they simmer under the surface and they dictate how we react to things. In the same way that my experience, when I hear phone-ins vilifying these children, or when I hear MPs saying that we're overdiagnosing, I think of every child I've ever seen who is trying their hardest, who is bouncing off the walls literally because they physically cannot sit down. That's not their fault. Be that because of trauma, be that because of another mental illness, be that because of ADHD. That's not their fault. So we have to challenge ourselves whenever we're faced with these conversations around mental health. What do we bring to the table? What baggage do we carry? And what response do they elicit from us? When you're talking to somebody who isn't adhering to the social norms or who interrupts you when you're having this really important point, how does that make you feel and why? And how does then that dictate your reaction? And I'd encourage you to think about that, because I strongly feel unless we challenge ourselves about the baggage that we carry, we cannot then think about strategies and solutions. And ironically, that's what actually ADHD does bring. So we've talked about deficits, and I disagree with the label. I should have said that from the beginning. ADHD doesn't, attention deficit hyperactivity disorder, doesn't do justice to what it actually is. It's an abundance of attention. It's just an inability to streamline it. So there's just so you're just constantly looking at things because you have so much attention and you need something to grab it. And that brings with it curiosity. It brings with it creativity. It brings with it problem solving, innovation. And you can just do a simple search and you will find a whole list of successful entrepreneurs and creatives and athletes. 8 to 10% of successful athletes are thought to have ADHD because it brings with it an amount of drive and hyperfocus. What people don't talk about in ADHD is when you find something you are interested in, you're hard-pressed to get you away from that. And that's why screens are so difficult in ADHD, because they actually do press all those buttons in the brain. All those reward centers that need stimulating, the screen is very good at that. And that's one of the difficulties that we are going to encounter in the years to come. Screens are now a part of our life. They're practically an extension of our arm. And we're constantly pressing those dopamine buttons in the front of our brain to the point where nothing stimulates us in the same way. So we all might develop a version of ADHD in one way or another because we're just glued to the phone. And then suddenly when we take it away, it's like you're literally withdrawing from a drug. Dopamine is the neurotransmitter implicated in addiction. It works in exactly the same way. So what are we doing about the way we live our life, the way we run our communities and our families that might be contributing to this? Speaking of families, it's interesting when we work systemically, so things like family therapy, rather than traditional psychodynamic therapies or individual therapies where you sit with the therapist. Within the family therapy, you have the whole family present and you discuss the problem or the issue from multiple lenses, and you think about how people relate, the interpersonal rather than intrapersonal. And what you find actually is that often children will behave in a way to manage the parental conflict. So they often, subconsciously, will become either the peacemaker, because that means that the conflict settles, and they might grow into a people pleaser or a conflict-averse adult, or they might become the rebellious one because it takes away from the parental conflict. And so often within family therapy, we look at what role is this child or adults within an adult system, what role is this individual playing within the system? And I found myself today thinking, what role are ADHD kids, primarily because that's my job, but ADHD adults as well, occupying in society? What are they bringing to the surface? What are they saying to us through their behavior and through what they can and can't do that's telling us about the way we are running our society, our communities? I don't have an answer yet, but I challenge you to think about it. I've completely lost track of time. Another symptom of ADHD. I mean, I don't have ADHD, but honestly, throughout this talk, I'm starting to wonder. I'm not sure if I can attribute it all to baby brain, but we'll leave that for another time. So, can it be helped? Absolutely. Can it be cured? No. But can it be helped? 100%. And there are multiple approaches, obviously, depending on your preference. Now, what's often in the news, as I'm sure you would have come across, is over-medication and giving stimulant medication to kids that are already hyperactive, and how does that work? We can talk about that, but also we have to think about the non-pharmacological approaches. So I'll touch briefly on medication and some of the contention and my experience of it to a degree in terms of the children that I prescribe for. So ultimately, if we're saying that dopamine is deficient in children and adults with ADHD, then we give dopamine, but we don't give it directly. We give a stimulant medication, which essentially pushes those buttons. So there are multiple different medications, all within some with the stimulant family, and then others that work on another neurotransmitter, another brain chemical called noradrenaline, both of which work in the front of the brain, responsible for attention, memory, and reward and pleasure seeking. Now, in brief, the way they work, if you think about the way messages are transferred in the brain, so ultimately you've got two nerve cells, and a message wants to get from one to the other. And that space in the middle, that's where dopamine carries the message to the next one. And so you'll release the dopamine, and then it will get to the other message. The way I talk about it to my kids at work is, you've got a postman who wants to deliver a letter. The letter is the message, the postman is the dopamine. And he goes through here, and then he delivers the letterbox on this nerve cell. And then he has to go back, sometimes. If he carries on, then he delivers the message further and further. So let's say the message is, stop, you're going to cross a road, stop, look both ways, that's the message. So the letter goes from this nerve cell to this nerve cell, and then it goes to the next nerve cell, and it goes on and goes on, because the postman's carrying on till he gets to his picture at the front door where he's made the delivery. If he's a good postman, he'll actually give you the delivery. If he's a bad postman, he'll leave it behind the bin, but whatever. But in ADHD, the postman actually goes, no, wait, I forgot, I've got another letter, and he goes back into this one. And then he wants to deliver again. And he goes back, because there aren't enough postmen to deliver all the different messages. And so that dopamine reuptake is how the medication works. It increases the amount of dopamine. Sorry, there are some notes that I've been asked by the young audience. Excellent. Our youngest members of the audience know the answers to the question that I've asked, which is what they would like you to know. So medication helps by increasing the amount of dopamine, the amount of postmen in the middle of those nerve cells to mediate those messages. And the medication, as I said, is stimulants. So you may have heard of Ritalin, methylphenidate, amphetamines. Very loaded medications. Theoretically addictive, effectively pressing the same buttons that cocaine presses. And that's where it gets difficult. You're giving kids cocaine. And hang on a minute, if these kids are hyperactive, why are we stimulating them more? And so it's, again, thinking about the intersection model, it's about making sure that they are able to press the right buttons to deliver the right messages. And actually, when we try to understand the neurobiology of hyperactivity, people think that it's too much energy, but it's actually focusing the brain. So you'll find that kids who are unable to focus will find their own way. So they will be rocking on their chair because that calms them. They will be doodling because that focuses the attention, in the same way that by doing that extra doodling, or by fidgeting, or by moving in one way or another, they are pressing those buttons. And I'm being distracted, I apologize. So the hyperactivity serves as a self-help function, so to speak. It allows them to focus their attention. Now, that's in brief about medication. And as I said, it's difficult because, again, when we look at research into ADHD, it's a mixed bag. So there are very few long-term studies. So there are very clear adverse effects for these medications. They can affect the cardiovascular system, they can affect your blood pressure, they can affect your appetite, they can affect your growth, and therefore we do robust monitoring of children when we prescribe these medications. But a lot of people say, well, you're impacting the development of this child. At what expense? And what benefit, rather. And so it's very much a cost-benefit analysis of how difficult is the experience of this child versus what are the adverse effects, and it comes down to informed consent and conversations with parents and children. But it's difficult because we don't have long-term studies. So I have a very frank conversation with my patients of, this is the data we have. I cannot tell you convincingly and reliably what might happen in 10 years' time if they continue on this medication. We just don't have that. And that makes it even harder to think about how we have informed conversations about this. And that's why it can be contentious. They're powerful medications. We don't have the data. But we do have the data about positive effects. We know that in the short term, they have they are successful at treating the core symptoms of ADHD. Interestingly, though, treating the core symptoms of ADHD doesn't always translate to academic improvement, which I found fascinating. So one would argue if they did a questionnaire that their attention improved, their hyperactivity decreased, their impulsivity decreased, but actually they didn't change their academic outcome. And so there's a debate there about what are we treating? Are we working towards conformity, or are we treating something else? And then what can be done outside of medication? Well, lots of things. Firstly, understanding the diagnosis. What does it mean? What does it mean for everybody involved? What are the implications? There's a lot of interventions around parenting, and this is received, it's difficult at times to have this conversation because parents can often feel blamed. The argument that if you're helping somebody with parenting advice, that means that what they're doing is wrong. And it's not the case. It's just that different children need different parenting. And being able to understand the way the ADHD brain works means you can adapt your parenting. So in the way you give instructions, using checklists to facilitate organization, using timers, being able to set goals appropriately. If you can work towards healthy immediate gratification, so breaking down goals to a multi-step process, so rewarding, let's say, a bedtime routine, rewarding going upstairs, getting ready, going to the bathroom, getting your pajamas on, brushing your teeth, rewarding every stage of that, be it stickers, be it whatever rewards you want to give. But being able to understand that that reward should be immediate rather than, oh, in 3 weeks' time it means you're going to be able to go to this football match. So being able to support in that way. And then there are, of course, social trainings, so being able to help children understand what is expected of them socially and help them understand their flavor. Being able to teach emotional literacy, so being able to identify emotions, having this conversation around mental health and around feelings, and arming children with a vocabulary where they can describe exactly what they're feeling, not just I'm feeling sad. What does it mean to feel sad? Are you feeling distraught? Are you feeling disappointed? Being able to break it down so they can understand those signals that they're getting and that they can thus communicate them appropriately and react to them appropriately. Because one of the difficulties is that children with ADHD can be seen to be oversensitive and overreact to things, and that can cause significant problems in the playground. And to be honest, the list is endless. There are multiple strategies that one can do depending on where the difficulties sit for the child. And I think this is important because often children say, parents will come to me socially or at work and they'll say to me, I don't know what to do. There's a 3-year waiting list. What do I do? I can't wait for that. And I say to them fundamentally, what do you want for your child? Are you going to go down a medication route or not? Because you can do everything without a diagnosis if you want a non-pharmacological approach. There are multiple resources online, there are motivational strategies, there are time management strategies. Fundamentally, you need to sit down and understand your child's difficulties, be that with school support, be that with family support, and look at each individual deficit, so to speak, and attack that in that way. My computer has crashed, which is not helpful. So I suppose I'll end with one thing, and I'll go back to strengths. So whenever I see a child, we spend a lot of time talking about problems, but actually we end talking about strengths. What makes you special? What superpower does ADHD give you? What can you do that no one else can do? And being able to help a child understand their strengths and what their brain gives them that's different to everyone else helps you build that self-esteem that allows them to traverse the difficulties that ADHD might bring them. And through their creativity and their curiosity and their problem solving, you can help them build a resilience that allows them to go on to be the successful person, whatever flavor of success that they want. And so I'll leave it there because my computer has decided that that's where we're going to leave it. And I guess I'll open to questions on this very broad subject.
صلوات على محمد وآل محمد. آل محمد. We have time for questions. Is there any questions from the audience?
Hello.
Hello.
Hi, assalamu alaikum.
Alaikum assalam.
I remember you mentioning how the children don't necessarily academically improve once they take medication. I'm wondering if, from your experience or the research you might have done, if there's a difference with, say, if a child takes medication before they start secondary school versus they start taking medication mid-studies, where perhaps before they took the medication, maybe they haven't learnt anything and they are overwhelmed. Like, do you think that might be like a factor, or do you think that there's a difference if they start taking medication before they start secondary school, or not?
Great question. I think timing of medication is important, primarily in terms of how a child responds to medication, because the slide that I am stuck on my laptop is the pains of a misdiagnosis, of a kid who goes through their academic career feeling that they're not good enough, and actually they realize that their just brain was working in a different way. And so a diagnosis that comes too late, and historically there's a lot of conversation about misdiagnoses in girls who present with a more inattentive subtype. Often you'll hear the classic stories of the rowdy boys who are jumping off walls and getting into trouble and risk-taking behavior and so on, and actually the quiet daydreaming girl who's just looking out the window just gets missed because she's not causing problems. And so with that then comes the self-esteem and the anxiety and the difficulty and the I'm not good enough and the shame. And so I think that's one contributing factor. But I think it's academic achievement is so multi-pronged. It's about having the right teacher. It's about finding what you're interested in. You know, we're not all supposed to be great at every subject. We're not. If we were all the same and if we all kind of went down one route, life would be very boring, and quite frankly, society wouldn't function, because, you know, if we're all doctors, then that's not great. So I think the only reason I mentioned it is it was the strongest car going through that intersection when I was talking about it, because it goes back to the conversation around the robustness of the evidence. And as I said, I am a very frank psychiatrist. I'm very clear about what we know and what we don't know. And so it's hard because the data doesn't, so the data in trials across the board doesn't translate into day-to-day results in the same way, because actually there are other factors. There are, you know, for example, the trial has to be medication or psychological intervention. You don't necessarily have the prong that says, what about if you're having both? What about if you had one before you had the other? So the way that trials are conducted can be quite rigid, and the data doesn't necessarily mimic real life in the same way. And I guess that's the point I was trying to make, is that tick boxes and questionnaires and online tests don't necessarily give us an accurate picture of what this child's experience is. Does that make sense?
Assalamu alaikum.
Alaikum.
You said that the way to medicate ADHD is give more dopamine, because the more dopamine, the easier it is to transmit a message from one nerve cell to the next.
Someone was listening. Yeah.
If we kept on giving them dopamine, because dopamine is technically a chemical which represents self-pleasure.
Pleasure, not self-pleasure.
Pleasure within what you've done. Say I do a good deed, I'd feel good about it.
Yeah, absolutely. Carry on.
And so the idea is there a possible way to give a sort of infinite source of dopamine? Because if you had a dopamine which could go on for, in the long-term idea, that would, to an extent, cancel out all long-term side effects. Because if you had, instead of just one postman, a whole post office which was constantly in function, or fleet of post vehicles, it would be much simpler. Is there, like, towards future areas, are we looking towards a way to find a medication that would work for a long-term idea on the ADHD area?
Very good question. Are you going to do the research to find it? Because I think you're well suited. So you're absolutely right. So I didn't go into this much detail because it's not relevant for everyone, but so we think dopamine is the way those letters are transmitted, absolutely. Now, there are some medications that act on dopamine specifically, and there are medications that act on other transmitters that control the dopamine. I'm struggling to see you there. And so those medications have a very different side effect profile, and actually for some a much more favorable side effect profile. And so that's what's called a top-down approach. You're absolutely right, but there are also natural ways to increase your dopamine. Things that actually our religion teaches us as well, in terms of social connection, in terms of being in nature, exercise, eating well, sleeping well. All of these things are fundamental to good brain health and good dopamine regulation. So medication is not the only way, but for some people, they need it a bit more than others. Thank you.
Any other questions?
If you were to suspect that an adult has like autism or ADHD, or and would it be like beneficial to give them medication starting now if they were like nearly 50 years old?
So I don't have clinical experience of working with adults, but actually a lot of what we're seeing in our clinic is that a lot of adults will then seek a diagnosis because of their child's experience. So now we have schools that are much better versed in neurodiversity, and a lot of referrals come from school. And then a parent will come to the clinic and they'll be giving the history of their kid, and they'll go, actually, this sounds a lot like me. And then they'll go seek an adult diagnosis. And some adults choose to take medication. They're affected in different ways. It depends on what the deficit that you're experiencing is. So some people find one of the descriptions used is that it just slows down the noise. And actually, interestingly, that's what a lot of people say about the current use of weight loss injections, that it slows down that food noise. It's similar, that brain fog where you've just got so many things going. And some people find it, they can organize their lives better. They're less irritable because they don't have that frustration with their kids when they're running riot, or with their colleague when they don't meet their target. So absolutely, yes, some adults benefit from medication in older age. Some people choose not to. Some people just want the validation of understanding, you know what? That's been me all along, and I've figured out how to make it work, and I'm good with that. My friend who got a diagnosis as an adult, we used to call her the spreadsheet queen. There was not a single thing that she did not have on a spreadsheet, to our benefit. And that's the way that she scaffolded her life. So she got her diagnosis and she hasn't chosen medication because actually her spreadsheets are working just fine for her. And that's okay.
Thank you.
Not to say that anybody who uses spreadsheets has ADHD.
Assalamu alaikum.
Alaikum.
Thank you so much for your talk. It's really interesting. Obviously, you mentioned that we should make our mosques and things we do within our community more inclusive for people that potentially don't fit into the kind of normal. I was just wondering what sorts of things we could do as a community centre to make our spaces a bit more welcoming, and also, I guess, like with the classes we run or with our madrasa, etc. What are small things that we can put in place to kind of make sure that everyone benefits from them? I
mean, I'm in a very fortunate position to have experienced both the madrasa and the kids club, and I can say that the teachers and the volunteers are wonderful at accommodating for additional needs in all directions, just be it quirks and flavours. So that's just a celebration of the people that make this community run, number one. I think first and foremost, before we get to community, as I said, we have to talk about the individual. What do we bring? Hands up, I've taught kids club, and there have been disruptive kids in the class. How do I respond? And I'm always aware whenever I do anything like that, I'm a psychiatrist in the room, I've got to lead by example. But it can be very challenging. And so how do we support ourselves as teachers and volunteers to be able to talk about those difficult moments and learn from them, number one? To be honest, I think that's the main thing. If we as individuals challenge ourselves about how we react to difference, that brings a broader question, a broader conversation rather, when we meet with each other. And from there, we can then allow people who are experiencing these things to lead. You know, patient participation is fundamental to the way services in the NHS are being shaped now. I'm sure there are many neurodiverse members of this community who might be able to speak to us about their experiences of what it's like to sit in a talk, and, you know, maybe if I had slides, someone might be able to actually pay attention to what I was saying. Maybe if I had a funky picture of the synapse rather than using things like that. I can't lecture you or anyone about neurodiversity because I only know it from an academic perspective and from so speak to the people and let the people tell you what they need.
Last question, Parvez.
Assalamu alaikum. Thank you very much for your talk. You didn't come down during the talk on the side of either it being a developmental trauma response versus a neurobiological disorder. Yep. Do you have an opinion, and does that change how we approach what does it change whether you give treatment, whether you give medication? And there's, I don't know, I've kind of on the internet, mushrooms.
Yep.
I can't pronounce them.
Psilocybin.
Yeah. What's the role of that?
There is a lot of emerging data about psilocybin, data that I am not up to speed with whatsoever. I put my hands up. So one of the difficulties is to make any kind of recommendation within the NHS. We are bound by the guidelines that our hospitals and NICE, National Institute of Clinical Excellence, give us. So I can't sit and read a paper and go, oh, this paper shows great, I'm going to start giving this out in my NHS clinic. That's not how practice works. And that's often difficult because I'll have parents who come to me and say, actually, I know these E-numbers affect my kid, can you recommend this stuff? I can't recommend it, but if a parent comes to me and says, this is working, I'm not going to force anyone to go and eat loads of E-numbers. Do you know what I mean? So that's number one. In my personal practice, patient and parent are expert. Your experience is your experience. I know what I know. We bring those two things together. So that's number one. So I can't comment on psilocybin. There is so much research to be done. We've had such an advance in research over the past 10 years in terms of imaging and what imaging has shown us. And David Nutt's lab has done a lot of data, a lot of research on the use of mushrooms and have shown. So when we talk about neurobiology, for example, people think that the brain can only be rewired or restructured through chemical means. So you take a medication, but actually we know from decades, I was going to say centuries, but that's a bit much, decades of data where therapy leads to brain changes. And what David Nutt's data is showing is that actually some of those changes that you see in the brain and long-term therapy can be mimicked through much shorter-term mushroom treatments. There's psilocybin rather than mushroom treatments. So I don't deny that there is scope for that, and I look forward to the research. I can't answer it right now. Am I going to get off the fence? I'll be honest. When I started as a junior doctor, going into my first CAMS job in ADHD, I was speculative. I had an open mind. And there's one patient in particular that, and my consultant knew what she was doing. She was like, come and see this kid with me. Okay. And literally bouncing off the walls. Happy as Larry, but just like jumping from one thing to another. And then I saw them medicated. And they were able to have a conversation. And they were able to engage, and I could see their personality. And in truth, that's why I prescribe, because, and I can say this, and I hope most of the people, if not everyone that I work with, will testify to the fact that I am not a pill-pushing psychiatrist in any way, shape, or form. I do not rush to medication first and foremost, but as the psychiatrist in the team, because we work within a multidisciplinary team, we have psychotherapists, we have psychologists, we have occupational therapists, something that I haven't touched on and that I need to touch on. When patients get to me, it's because they've tried the other things and actually they're at a severe end of the spectrum that they need medication. And so in that instance, I can say that there is a chemical process happening. What does that mean, though? In the same way, it might just be a quicker way of them getting it. It's just that they don't have the time to devote. Their parent is running 3 jobs, trying to look after 3 kids. They don't have the space to be able to do those psychological interventions. We work in a very pragmatic, socialized health service, and I think that for better or worse, sometimes influences the way we work. So no, I'm going to sit on the fence. Just going back to OT, which I didn't mention, a lot of people say to me, oh, should I go private? And there are two professions that are underrepresented within CAMS teams, occupational therapy and educational psychology. And again, largely, educational psychology was much more available 10 years ago. Sadly, not so much now. But educational psychology can help families understand the specifics of your individual brain and how it works. So your working memory, your verbal reasoning, your spatial awareness. And it gives you a breakdown of how your brain works. So then I can say to a kid, this is your superpower. And that's really helpful in understanding, rather than going, this is your problem, this is what you're not good at. It can help me work with a kid to go, well, you're going to find maths really hard because actually numbers are not your thing, but that creative element, you're going to thrive there. So that's number one. But occupational therapy is very important and can be life-changing for these kids because, I mean, I don't think we have enough time to go into sensory processing, but the way children, so if we think about dopamine implicated in the movement parts of our brain, the way we move then influences our reward centers, and that's why children fidget in a hugely simplified way. So occupational therapy can help children understand their sensory profile. And now when we talk about senses, we talk about the 5 senses that we know, but there's 3 others. There's vestibular, there's interoception, and there's proprioception. Vestibular is the way you balance. Interoception is how you understand your internal cues. So how you feel hunger, how you feel continence or incontinence. Let me sit down, please, Habibi. And then proprioception is your awareness of your body. So if I, like my classic example is if I close my eyes and I raise my hand, I know that I've raised my hand because my body can feel that. And for a lot of children with ADHD, those 3 plus the 5, now I always get the 5 wrong. I get the difficult ones easy, but the 5. So smell, taste, touch, say them. Excellent. So all of those things, when you understand your child's sensory profile, you understand when they're seeking that climbing on the walls because they need to feel that push against their body. And so occupational therapy, in short, can really help a child understand their body and what their body needs, and therefore can help them learn how to regulate in a bid to demedicalize what I've just said over the past hour.
Thank you very much. We'll have to end there. Salat ala Muhammad wa ala Muhammad. Yasmin, Dr. Al-Asady is around if you have any questions afterwards and want to speak to her directly. Just a couple of announcements. Next week we have Muhammad Zain Dada who will be speaking to us on navigating a career in film, theatre and TV. The week after we have Sukaina Rajwani, who's the mother of Fatima Zainab Rajwani, who will talk about her daughter's story, the price of dissent against the genocidal arms trade. We also have Visit My Mosque on the 5th of October, and a film on the Palestinian Solidarity from the Palestinian Solidarity Campaign, and that's also in early October. Please look at our website to find out more. Every Monday we have Mums and Tots and Ladies Pilates in the evening. Every Tuesday we have yoga and ladies exercise classes. Wednesday karate and taekwondo. Thursday Dua Kuma and Surah Yasin at 8 o'clock. Friday the Salam Talks and Women's Walking Club on Saturday, as well as tuition, and Sunday tafsir classes and Husseini Madrasa and the Soul Kitchen. Please do look on our website sikkim.org.uk if you'd like to find out more. Salat ala Muhammad wa ala Muhammad.